Okay, today I'm going to talk about aniseikonia, which is a very common problem in ophthalmology clinic. So in this talk, we're going to dive down into the basic principle of optics behind aniseikonia so we have a better understanding of what's going on. And we're also going to talk about the basic principle of all the treatment options available so we have better understanding and we can take care of our patients more effectively. I have nothing to disclose. So aniseikonia means not equal image. It can be a difference in image size between two eyes. One eye sees things bigger and one eye sees things smaller, or it can be a difference in the shape of the images as well. And from the definition, you can probably tell that aniseikonia is a binocular condition. That means the patient is going to experience the symptoms of aniseikonia only when both eyes open. And first, we're going to review a basic normal physiology of functional mechanism. So in normal people, when we look with both eyes, our eyes will have a simultaneous perception of the right eye and the left eye. And our brain have a functional mechanism that allowed us to fuse the image so we see only one object, like we're seeing this cat right now. In order to do this, the brain needs an input of the images from both eyes that are similar and clear. So similar and clear. Let's say the two eyes see things differently now. So this will increase the demands of the functional mechanism, and this can lead to the symptoms like eye strain, headache, dizziness, vertigo, or difficulty with reading. So when the images are so different, if it exceeds the threshold of functional mechanism, that will lead to diplopia or even suppression in children. And normally, in average, adults can tolerate around 5 to 7% of aniseikonia, but this number varies among individuals. Some people can tolerate much more, and some people develop symptoms of aniseikonia despite a very small amount of aniseikonia. The way that we write the value of aniseikonia is very similar to when we write the prescription for glasses. For example, when we write the prescription for glasses, if we write -4, that means the eye itself has too much plus power, so we need -4 to correct it. So we're going to write the amount of the correction. And in the same way, in aniseikonia, we're going to write as the value is the image size relative to the other eye. So we're going to write only the value of the right eye. And we're going to write what we're going to use to make the aniseikonia disappear for the right eye. So for example, if the right eye sees things 5% larger than the left eye, we're going to write that as -5% aniseikonia because we need to -5% in the right eye in order to make aniseikonia disappear. Okay. And here comes the important question, what caused aniseikonia? And this diagram is one of the key messages of this talk. And we can see that when we're dealing with a patient with aniseikonia, there are 3 possibilities. The first thing, which is by far way more common than the other 2, is the problem with the optical magnification of the eye. And the second thing is the receptor distribution in the retina. And the third thing is the brain cortical processing. So let's talk about the first one. The goal of optical magnification of the optical system of the eye is to focus the light from the object on the fovea. And if the eye have the refractive errors, we call that ametropia. This can result in magnification or minification of the image. And also the optical devices that we use to correct the refractive error, like the spectacles, this can also have an effect on the image size as well. And we are going to go through that in details in a couple minutes. So let's talk about refractive errors. When the eye have refractive error, we call it ametropia. And mainly we can classify ametropia into axial ametropia and refractive ametropia. So in axial ametropia, the refractive error is the result from the change of the axial length. And here you can see that if the eye gets shorter, that's axial hyperopia. The light will focus behind the retina. And if the eye is too long, that's axial myopia, and the light gonna focus in front of the retina. And in the similar way, for refractive emmetropia, that's a refractive error that is a result of the refractive power of the eye itself. For example, in refractive myopia, the eye power is too weak, it's too strong, so the light focuses in front of the retina, and in refractive hyperopia, the eye power is too weak, so the light focuses behind the retina. And the reason why I have to mention this is because in axial emmetropia and refractive emmetropia, they respond or they react differently to the optical devices. So in this talk, we are going to focus on aniseikonia. So now we're going to pay attention to retinal image size. And in this picture, you can see that the retinal image size is the area between the optical axis and the sheath ray. Sheath ray is the red line in this picture. So the angle that's subtend on the retina, that area is going to determine the retinal image size. And now we're going to see what happened to the retinal image size when we have axial emmetropia with and without correction, and what happened to the retinal image size when we have refractive emmetropia with and without correction. So we have a total of 4 conditions to look at. Now let's take a look at condition number 1. In patients with uncorrected axial emmetropia, you can see in this diagram that if the eye is shorter, that's axial hyperopia, the eye will see the image that is smaller than emmetropia. As you can see that H1 is less than H2. And in the similar way, if the eye is too long, that axial myopia, that eye will see the image bigger than emmetropia. So that is H3 is more than H2. This is the example for this condition. You can see that the left eye, the prescription is +4, that axial hyperopia. And the right eye is axial myopia. You can see that the eye is much, much bigger. And when they look at the cat again, this is what they're going to see. So both images are blurry because they have refractive error. So the right eye is going to see bigger image, and the left eye will see smaller image. So this patient have aniseikonia. And now we're going to see what happened to the retinal image size when we try to correct this with spectacles, which is condition number 2. Fortunately, there is a law some of you might familiar with that is called Knapp's law. And in this law, it's stated that if we place a correcting lens at the anterior focal point of the eye, which is 17 millimeter in front of the cornea, that Dr. Sweet just mentioned earlier about reduced schematic eye, it will produce the image that has the same size regardless of the axial length. So you can see in this diagram that if we place the lens 17 millimeter in front of the eye, no matter what the eye is short or how long it is, it will always produce the same size image. So this is what happened. Is this the same eye from the last example? So we place the correcting lens 17 millimeter in front of the eye, and now they see the cat clearly and in equal size. This is the theory. In clinical practice, in reality, there are 2 limitations of this law. The first is that 17 millimeter vertex distance is a little too far. Imagine you have to place this spectacle that 17 millimeter in front of your face, while normally the average vertex distance for the spectacle is around 12 millimeters. So 17 is too far. The glasses might come down your nose or something like that. And the second reason why Knapp's law is not applicable all the time in clinic is that most patients doesn't have only axial components. They also have refractive emmetropia. So it's not going to correct all the problem that they have. But despite these 2 reasons, in reality, the patients with predominantly axial component tends to do very well with glasses. And this reason because let's say in this picture, we put the lens at 12 millimeters. And take a look at the left eye first. The prescription is +4, so it's axial hyperopia. We put this eye without correction, we'll see smaller image, right? Remember that. And we put the plus lens in front of this eye, and the plus lens itself, it magnifies. Imagine, when we talk about plus lens, imagine magnifier. It acts like a magnifier. So the lens itself compensates with the retinal image size in the naked eye. So the aniseikonia might not become 0, but it become reduced into the tolerable level. So this is what they're going to see. They're going to see clear, similar image size, and this is why in axial component, the patient usually tends to do very well with glasses, and we usually have no problem with that. All right. Now let's take a look at the refractive emmetropia. In refractive emmetropia, like refractive myopia, refractive hyperopia, they all see the same image size. As you can see in this diagram, the sheaf ray is stay the same. And the easy way to think about this is to think about the projector that we use in the classroom. If the projector is focused perfectly, that resembles 20/20 vision, we're going to see the text very clearly. But if the projector defocus, whether it's defocused anteriorly or posteriorly, we're going to just see blurry image. But the image doesn't get bigger or smaller, it just blur. And this is why without correction, refractive emmetropia, they have no problem with aniseikonia. And you can probably tell that it is the last one that has the problem, which is when we try to, oh, this is the example. Yeah, so they see same size of the cat, blurry, just blurry, but not bigger or smaller. This one is the one with the problem. When we try to correct refractive emmetropia with glasses. As I mentioned earlier, plus lens acts like magnifier, minus lens do the opposite thing, is minify. So in this diagram, you can see on the top that in naked eye, the retinal image size is that area between the red arrow, and when we put the plus lens in front of the eye, it increases the subtend angle on the retina, so the patient sees things bigger. Imagine looking through magnifier. So the same example, we put the plus lens on the left eye, so the left eye sees things bigger. We put minus lens on the right eye sees things smaller. So when the patients have difference of the refractive error between two eyes, when we try to correct it with the spectacle, this is when we're gonna face aniseikonia, and this is the most common scenario that we see in the clinic. All right, and we can see that it's condition number 4 that is the problem for us because we try to correct it with a spectacle. So now in this section, we're gonna go down into how spectacle affect the image size, and we're gonna learn about this spectacle magnification. So the definition of spectacle magnification is straightforward. It's just the change in the retinal image size of the corrected eye compared to the uncorrected eye. And the way to calculate it is there are 2 factors that affect the spectacle magnification. We call it power factor and shape factor. And we're going to go through into the details right now. We're going to talk about power factor first. And don't be afraid of the mathematical equation. I just want you to see the correlation of the factors. There's no calculation or anything like that. I just want you to see that there are only two factors that affect the power factor. And there are lens power and vertex distance. Lens power is straightforward. Imagine you using +8 magnifier versus +4 magnifier. You're going to see bigger with +8, right? And the other way is true for minus lens. The more minus power, the more minification. You with me? Okay. So from this knowledge, what we're going to do from this knowledge to help our patient is that I'm going to introduce you to treatment option number 1, which is we can compromise the lens power between two eyes. We sacrifice some VA to achieve more similar image size. So this is spectacle with compromised lens power or compromised VA. We can try to undercorrect or overcorrect one spectacle lens. So one eye might not see 20/20, it can become like 20/30 or 20/40, but the patient see more similar image size. Okay, so this is one option that we can choose from. And the factor number 2 is vertex distance. Vertex distance, let's talk about the plus lens. As you can see in this diagram, that if we move the plus lens away from the screen, the image, which is the green arrow, it gets bigger. That means for the plus lens and minus lens, if we move the lens away from our eyes, it will increase the magnification and minification. For example, on the right side, this is Sherlock Holmes, that he is using the magnifiers. So if he put the magnifier away from his eye, what he's going to see is he's going to see things bigger. So in order to correct aniseikonia, we can reduce the vertex distance, put the lens closer to our eyes, and that will decrease magnification and minification. Okay, as I mentioned earlier, the average vertex distance of the normal glasses is around 12 millimeter. So we can decide to make it like 10 millimeter or 8 millimeters, and that will reduce the magnification and minification. But what if we make it sit on the cornea? And that is treatment number 2, is contact lens. So contact lens work on power factors by making vertex distance 0. And when we put 0 in that equation, the power factor becomes 1, which means there is no magnification or minification. And this is why contact lens is the first choice for the treatment of aniseikonia. If the patient can tolerate it, can take care of it, we usually consider contact lens first. This is a part of the spectacle magnification, but I would like to mention another advantage of the contact lens is that it has no anisophoria. And the definition of anisophoria is that it's a muscular imbalance that varies, that like worsen in particular direction. For example, if we wear the glasses that on one side is -5 and on the other side is +3, there's so much different. When we look down, like we're trying to read the book or something like that, the right eye will experience the base down prism and the left eye experience base up. And when both eyes experience different amount and different direction of the prismatic effect, this will cause anisophoria, and if it exceeds the fusional amplitude, that will result in diplopia or suppression in children. And the reason why contact lens has no problem with this is that the contact lens always move with the eye, so the eye always look through the optical center of the lens. And this is for the resident. This is a review. This is called Prentice rule. We can calculate the induced prismatic effect by multiply the distance that we look far, like from the optical centers, and multiply that by the lens power. Okay, and that is the power factor, 2 factors, lens power and vertex distance. And now we're going to move to shape factor. There are 3 things that we can adjust of the shape factor. There are base curve, and usually we adjust on the front surface, and lens thickness and refractive index. So let's say if we want to make the patient to see things bigger on that eye, to magnify things, we can make the base curve steeper, and we can make the lens thickness thicker, and we can use the material of the glasses that have higher refractive index. So this is a summarizing table for the things that we talked about. There are power factor, shape factors, and the reason that I made this table is that I'm going to introduce you treatment option number 3 is that we have a thing called Aniseikonia lenses. And Aniseikonia lenses is a customized lens that we have to calculate for each individual. So the magnification is balanced between 2 eyes. So this option can be considered in like patients who cannot tolerate contact lens, like in older people or in people with like hygiene problem with taking care of contact lens. So we adjust all these 5 factors to make the lens that the image size are balanced between 2 eyes. And as you can tell, this is very technically demanding and it's going to be expensive. And you can see in the picture that the lens on each side can have a different appearance, so it might have some cosmetic problem with that as well. You can see that on one side the lens is so thick and the vertex distance is different, the material is different, the base curve is different, and yeah, so this is not a common option that we usually do. So this is the 3 treatment options as we talk up to now. And just for review, contact lens, the principle is there's no vertex distance, so magnification is 0, that we work on the power factor. No anisophoria because it always moves with the eye. We can compromise lens power of the spectacles, and we can use the Aniseikonia lens, which is customizedly designed for each patient. And now I'm going to introduce you with treatment option number 4, which is we can use combination of spectacles and contact lens, so wear spectacle and contact lens at the same time. And we can do that by using the plus spectacles with minus contact lens, or we can use minus spectacles with plus contact lens. So does this sound familiar to you? When we look through a 2 set of lens, one lens closer to the object, one lens closer to the eye. And yes, this is the principle of the telescope. So plus spectacles and minus spectacle, that Galilean telescope that help magnify the images. Minus spectacle plus contact lens, that reverse Galilean telescope, so the image would get smaller. This is the optic review. We have 2 main kinds of telescope, Galilean and Cambrian telescope. And what we're going to use here is Galilean telescope. And it provides, when I think about Galilean telescope, I think about the surgical loop that we use to do the eyelid surgery or strabismus surgery. And of course, it has to provide upright image because you cannot do surgery upside down. And when I think about Cambrian telescope, I think about astronomical telescope that we use to look at Mars and Jupiter. And that's inverted image because who cares if Mars is upside down, you know? And you can tell that astronomical telescope has a very long tube compared to the surgical loop that we use. So when you calculate the tube length, it's a sum of their focal length versus the difference between the focal length. Yes, and that is the summary of what we talked so far. And this is the last option that I'm going to introduce you because I told you in the first slide that it is a binocular condition, so you always have a choice to occlude one eye. And you can do that by occluding a whole frame or occluding only the central part of the frame. And I recommend using this as a last option. And as many or all of us are ophthalmologists, we can correct it. There are some surgical options that we can do. For example, we can do refractive corneal surgery to correct the refractive emmetropia. We can do LASIK, PRK, or whatever they are. We can do refractive lens surgery. Clear lens exchange has been proven to help with aniseikonia, or we can do like secondary phakic intraocular lens also. And that is the end of the optical system, number 1. So now we're going to move on to the cause number 2, which is the retina problem of receptor distribution. So From my personal experience as I'm neuro-ophthalmology trained, I also got some referral from other ophthalmologists or other physicians that the patient have aniseikonia, and when they do the refraction or they do the corneal evaluation, everything looks fine. They have no anisometropia. Their refractive status looks fine. So they think that it has to be the problem with the brain because the patient keep complaining that, oh, one eye see things bigger, one eye smaller. So they think that, oh, let's refer to neuro-op to evaluate the brain. But I'm going to tell you that most of the time is the problem with the retina. And the retina can cause aniseikonia by changes in the receptor distribution. And usually what we see, we can identify the cause easily by using the OCT, and most of the time we see epiretinal membrane, sometimes with pseudohole, sometimes macular hole, cystoid macular edema, or sometimes you can see like the disruption of the ellipsoid layer that might suggest some prior pathology like previous central serous chorioretinopathy or something like that. And these retinal pathology can lead to aniseikonia because it's changed the distribution of the photoreceptor of the macula. Like it may make them closer together by compressed it together, or it makes it spread out than it should be. And that will lead to how the brain interprets the size of the image. So I have a quiz for you. You can see the OCT on the right side, and you can see at the top there is a line, hyperreflective line, that's epiretinal membrane. And you can see on the photoreceptor level that it looks pinched up like this by the epiretinal membrane. So here, the photoreceptor come closer together. So my question is, what do you think the patient is seeing? Are they seeing macropsia, which is the bigger image, or micropsia, which is smaller image? And this is always a fun question for the resident. And yes, the answer is macropsia. And here's why. Let's say we're looking at this pencil with our two eyes. And normally in picture A, this pencil, the light from the pencil hit 10 photoreceptors. But when the photoreceptor come too close together, now it hit 15 photoreceptors. So when it hit 15 photoreceptors, the brain is going to think that, oh, the object must be very big because this time it's hit 15 photoreceptors. So that's macropsia. And it's also true the other way around, that if the photoreceptor become too far apart, this time it will hit only like 6 photoreceptors, and the brain going to think, oh, the object is so small, it hits only 6 photoreceptors. And this is how the retina problem produced aniseikonia. And the last one is the problem with the brain, which is really rare. I am neuro-ophthalmology trained, and I haven't seen any cerebral aniseikonia before, to be honest. Because cerebral usually when the patient with brain problem, they experience aniseikonia because of the outer cortical function, like the abnormality with the brain. And you can probably differentiate that from the other two causes because most of the time the symptom is transient. It comes and goes. It's not going to stay there with you all the time. Unlike the optical system problem or the retina, that is just going to stick with you all the time. And usually the patients describe as seeing like the whole world is getting smaller or the whole world is getting bigger. It's not like the difference between both eyes. You know, it's like a bilateral micropsia or macropsia, something like that. So it generally affects both eyes and transient. And here's some neuro-op for you. I saw a 33-year-old male with chief complaint of recurrent transient micropsia. He described it as when he drives and all of a sudden everything around him started to get smaller, smaller, smaller. And then the interesting feature is that everything seems to turn into like a cartoon-like appearance, like you can see in this picture. Like the car, the people, it looks small and turned into like a clay model or something like that. And the funny thing is that this patient is a photographer, and he can exactly describe that to me as what he saw is called the tilt shift effect, which is a photography term that when we take a photo, this is a real place at BTS Siam Square, as you can tell. And in photography, they can do the tilt shift effect to make things look like a tiny model. And he said, yes, this is exactly what I saw. And this going to happen for a few minutes, and then everything starting to come back to normal. And yeah, I think a lot of you might think that this sounds like psychiatric problem, but before referring to the psychiatrist, this patient looks like very good insight patient. You know, he looked like a normal guy. Yeah, and so we did the workup like MRI and EEG to rule out epilepsy, seizure, something like that, and everything came back negative. So this consistent with the diagnosis of what we called the Alice in Wonderland syndrome. So if you ever watch Alice in Wonderland, Alice like eat a mushroom and then she gets smaller and then she gets bigger, something like that. So in Alice in Wonderland syndrome, it's relatively rare syndrome, and the object seems much smaller or much larger than they usually are. And the patient is usually like healthy people, migraine people, and the etiology is not well understood. It's possible that it's related to migraine, or it might be some kind of migraine aura, something like that. So I give you this example because I want you to see how cerebral aniseikonia feels like, and it's gonna be like transient, bilateral, yeah, something like that. So it can be found in Alice in Wonderland syndrome, Chaow syndrome, which is release hallucination in patients with like homonymous heminopsia, or hypnagogic hypnopompic hallucination. That is a hallucination that you saw when you like wake up in the morning or when you're trying to fall asleep. Yeah, so that's the end of my presentation. So the summary today, the key point is that when you're dealing with a patient with aniseikonia, there are three possibilities. And you think about the optical system that is way more common than the other two. It can be the retina. Think about the retina first before think about the brain. And we reviewed about the retinal image size in axial and refractive emmetropia, with correction, without correction. And because the spectacle is the main cause of aniseikonia that we see in the clinic, we reviewed about the spectacle magnification, about the power factor, shape factor, and these are the factors that we can correct to help our patients with aniseikonia. And so we understand the principle of all the treatment options, like contact lens, why it works. Spectacle, we can compromise the lens power. We can use a cyclonic lens. We can combine this contact lens and spectacle to make a telescope, and we can always occlude one eye. And we also review other causes of aniseikonia, which is retina and the brain. So thank you so much for listening. I hope you enjoy it.